I think the biggest misconception that kind of irks me all the time when people, I guess that's how social media has just stamped it, right? You hear testosterone and the first image that goes through most people's heads is Arnold Schwarzenegger or Phil Heath and just building muscle, right? That's what everybody thinks of.
Right.
But it's so much more than that. It is the fundamental chemical messenger in your body that's got all these pathways it works on. And when it goes down, you're not just losing muscle mass, like it affects your neurotransmitters, your dopamine, your norepinephrine, all these things that make you feel happy and good about yourself and does the positive reinforcement pathways, right? So it's good for guys to know that it's not just testosterone. Testosterone is just not linked to muscle mass, right? There's got all these other effects that helps you live a better life.
Right. Yeah, because the mood is probably the number one reason that I try it in people, right? And I'm not as dogmatic adhering to the guidelines on it as I used to be. It used to be, oh, you need 2 levels less than 300, otherwise I'm not going to prescribe it.
We can do a whole podcast on that, on where guideline-based care has gone. And it's good to see how regulatory bodies are peeling off the black box warnings. And even for testosterone, forever it had the black box warning for cardiovascular risk, which they've repealed, right? So like, I think I think it's probably the entrepreneurial side, ventured out of the box of guideline-based care to see anecdotal evidence in patients we treated to see, oh, this stuff actually works. I'm going to try it on this guy. Oh, this worked for him. So you see so many of those cases, right? You start seeing, okay, maybe the guidelines aren't the best way to go. Is that how you feel?
Yeah, for an individual, they're not. For a population, sure, right? Because that's what they're designed for. But I've seen it both ways. I've had people come in, their testosterone's like 350, and they feel like crud. And I'm not trying to jack their testosterone up to like 1800, right? There's no reason for that. But let's see if I can get you to 600, 700, right? And see how you feel, right? I can do that relatively easy, low doses, very safe, right? And if you feel better, great, right? Then we know that there may be something here with the testosterone that was causing that issue. If you don't feel any different, okay, let's investigate other reasons for this to be happening. Because I think it's an interesting theory that I've had. I've seen people with testosterone like a 150 and they have no symptoms, they're jacked, they feel great. And I think
they're jacked.
Yeah. I think it might be like some people have a hyper-functioning testosterone receptor.
Yeah.
Right. And so that low testosterone is protective. Right. And so what happens if I give that patient testosterone without any reason to?
Probably the opposite effect. Right. So just for our audience. Right. And that's one of the core missions of this podcast is to be easy to understand. When you say hyper functioning testosterone receptors, what does that mean? Yeah.
So we know that there are certain things that are conserved. Right. Testosterone needs to bind to something.
The lock and key.
Right, the lock and key, right? But we don't all have the same lock. There are different locks, right? So some people's locks may function average, right? Some people's locks may function worse. Like it's a lot harder for the key to open the lock, even though it's the right key. Some people's, the locks will open to just about anything. Right. And so these people, like they get a profound downstream, effect. So what happens when testosterone binds to that receptor? It's just much more effective. And so in these people, the body will try to regulate that to make sure that nothing bad happens. So it'll make less testosterone because it doesn't need to make as much because it's getting the same effect with less. So these are the things that I have to think about. And, I'm a very symptoms focused physician, right? If I'm just treating a level, anybody can do that.
Exactly.
Right.
And that's why we always say, don't treat the labs, treat the patient, right?
Exactly.
If you just go off the numbers off of a sheet, like you said, there's so much variability in that, but the patient knows or the client knows that something's off. So that's where I think good medicine is practiced typically, if somebody's willing to listen to them. I think that's also a big problem in our healthcare system today, where physicians don't have enough time to spend with the patient and have that conversation to actually get to the bottom of this is how they're feeling.
Right.
Right.
And when we designed a better, we collect a lot of data beforehand. So before I even meet with people, I'm getting a lot of information about them. And then I go through that information, I go through the lab work, we do a very comprehensive initial lab assessment. So, and then I can start piecing through things together. And then we talked about the first question I ask them, even though I have that data, I want to hear in their own words, what are your goals?
Yep.
Right? Because that's going to tell me the frame which I apply everything else through.
Yep.
Right? Because it's no good to me if I recommend something to somebody and it's not in line with their goals.
Yeah.
What's the point?
Yeah, because everybody has different goals, right? Some people might want recovery from a previous injury. Some people might want to live longer. Some people might want to just get jacked. But at the end of the day, it's what they want, right? It's not what we think they want.
Right. That's that old paternalistic model of medicine. The
yeah.
physician knows best, do what I say.
Yeah.
Right. And that's not the kind of physician I am. I want to help people achieve their goals because that's going to improve their quality of life.